It's a beautiful case, and especially also it will help you in revising all the endodontic diagnosis and also the irreversible pulpitis versus irreversible pulpitis. So it's a good way to revise all the endo concepts that we've been doing related to pulpitis. And also talks about the RCT, the emergency treatment of irreversible pulpitis. So a good revision point, just like I provided you with the clinical article of endodontic diagnosis, this case would be an add-on, especially when you're reading that article, you can add that you can revise case number 47 along with it. So information will come together and it would be a useful way of revising entire endo concepts in one go. So let's begin with molar endodontic treatment. It's about a 52-year-old man who presents with pain from a tooth in lower left quadrant. What is the cause and how will you treat him? So he can locate the side and the jaw, but he cannot tell which particular tooth because it's coming only from the quadrant and which tooth is not mentioned. And it's a 52-year-old man. Now you have to identify the etiology and the treatment and of course the diagnosis for him. So the patient complains of pain from a tooth in a lower left quadrant, but is unsure which tooth is the cause. So that indicates that it's a poorly localized pain. That is a very important point when we come to the diagnosis. Then what specific questions would you ask with regard to the history of pain? So now to come to the endodontic diagnosis, the nature and the factors and features of pain are extremely important because they help you in identifying the cause and reach the final diagnosis. So the pain features are extremely important, and I've told you also answering any questions in terms of endodontic diagnosis, you really need to know that what is the nature and duration and other features of the pain. So that becomes your most important criteria in identifying the endodontic diagnosis. So let's see what of the feature is important and what that indicates. So the question would be, when did the pain start? So that would give you an indication that since when the problem or pulpal inflammation is begun. So the pain started about 8 months ago for this patient. That means there is some kind of pulpal irritation from last 8 months. It started 8 months ago. Now, did anything start or provoke the pain? That question will give you information that whether it's a stimulated pain, that and a stimulus stimulates it, or it's a spontaneous pain, right? A stimulated pain belongs to reversible pulpitis and also the early stages of irreversible one. In the late stages of irreversible one, it becomes usually spontaneous, right? So initially it was hot and cold food drinks brought the pain on. So initially it started with a stimulus, and now maybe it is spontaneous pain. How long did the pain last at that time? So when it began, what was the duration of the pain? So only for a few seconds is a characteristic feature of reversible pulpitis. When it goes on for more than a few seconds and about a minute, then it becomes your irreversible pulpitis, right? I've explained all of it in the endodontic classes as well. You have done all these diagnoses and features with me. Now this is the time we're going to review and develop a deeper understanding and have a good revision also of those endodontic diagnoses, right? So only for a few seconds, reversible. If it lasts longer, then it's irreversible pulpitis. What is the characteristic of the pain? So the nature of the pain characteristic, like if it's sharp, it indicates reversible. If it's dull and throbbing, it indicates irreversible pulpitis. So initially it was sharp, but now it's dull and throbbing. Also indicates that initially it was reversible pulpitis, which has now become irreversible one. Other than the change in the intensity of the pain, has it changed in any other way? The pain is still brought on by hot and cold foods and now lasts for hours. So it is still stimulated. It is not spontaneous yet, but because it is more than a few seconds and goes on for hours, it is characteristically irreversible pulpitis, and it is dull and throbbing also now. Does the pain start spontaneously? Does it wake you up or keep you awake at night? So initially it was never spontaneous, always with a stimulus, but now the pain intensity has increased over the last 2-3 days. It has in fact woken him up at night. That indicates that now even at night it has kind of become even a spontaneous pain, right? Does anything relieve the pain? So again, an important characteristic of irreversible pulpitis, paracetamol has a mild relieving effect. So analgesics are required to subside the irreversible pulpitis pain. Analgesics are not required to subside the reversible pulpitis pain that fades away on its own. Is the tooth painful to bite on? No, not yet. So that means it is still the early stage of irreversible pulpitis, because in late stages of irreversible pulpitis, the periapical area also gets involved and there becomes tenderness on percussion. Although these early and late stages are only histological classifications, they do not make much impact clinically. The only clinical impact that would have is that late one would develop periapical involvement and you would get a painful tooth on biting as well. Otherwise, treatment-wise, both early and late one, they require root canal treatment. It is non-restorable in terms of non-preservable pulp. So you have to extirpate the pulp and do the RCT even in the early stages and the late. The only difference is histological and involvement of how much pulp gets involved and also the periapical area involvement. So there becomes a little bit of pulpal periodontitis in the late stages of irreversible pulpitis. Now, the patient is new to your particular practice, but has always attended the dentist regularly. The patient is fit and well. On the basis of what you know already, what is the likely diagnosis? So we have seen all the questions and answers to them, and we have reviewed each answer also in identifying the proper probable diagnosis. So now, after coming to a conclusion from all these questions, you now know that it is certainly caused by pulpitis. It is brought on by hot and cold and poorly localized, and it has progressed from intermittent pain, suggesting initially irreversible pulpitis when it was only a few seconds, and now because it goes on for hours, so it is now irreversible pulpitis. So the severity, the duration suggests that pulpitis is irreversible now. What is irreversible pulpitis? So irreversible pulpitis is a concept rather than a well-defined clinical condition. Pulpitis is usually chronic and progresses intermittently and unpredictably with or without acute phases. At some stages, the pulp is irretrievably damaged, probably because of pressure from inflammation which impedes the pulpal blood flow. Now this causes the loss of tooth vitality. And ability to predict pulp necrosis would be useful when deciding a possible management option. Unfortunately, the clinical symptoms which accompany pulpitis are variable, especially multi-rooted teeth. The pain is a subjective sensation, and severe pain of long duration and spontaneous pain, waking up at night, requiring an analgesic to subside it, they all indicate irreversible stages of pulpitis. However, predicting the future course of disease is never reliable, and making the diagnosis involves an element of uncertainty, depending on the operator experience. So extraoral examination shows that TMJ is normal and there are no palpable lymph nodes in the area, so it has not spread yet. It is only a localized pulpal infection. Now, on examination, you discover poor oral hygiene and gingivitis around posterior teeth. Dentition is moderately restored. In the lower left quadrant, the second permanent molar tooth has an occlusal amalgam, and the premolars appear sound. Now, what part of examination would be most useful and why? So what would be your examination? Now you have identified the diagnosis, which is your irreversible pulpitis. So teeth should be percussed to establish whether any are tender, Then adjacent, apparently healthy control teeth should be percussed first for comparison. Then tenderness indicates inflammation in your apical periodontal ligament, and causes would include very late stage irreversible pulpitis, which I just mentioned to you, that in cases of late stage irreversible pulpitis, your periapical involvement has occurred and the person develops apical periodontitis, which becomes tender on percussion, and then the tooth becomes localized. So that is why in the early stages, when it has not involved the periapical area, there is no pain on biting, the tooth remains poorly localized. Only in the late stages of irreversible pulpitis, it becomes localized. And that's why this patient, he had no pain on biting, no periapical involvement yet, and that's why he came only with a poorly localized pain. He could not pinpoint the tooth. Now, the palpation of the mucosa overlying the tooth apices with the fingertip should also be palpated. Then tenderness indicates the extension of inflammation from the PDL into the surrounding bone, which indicates the activity of any inflammation that is present. Affected teeth are compared with clinically sound teeth. Lower molar apices are close to lingual mandibular cortex and must be palpated lingually as well as buccally. Then coming to mobility assessment, mobility is increased slightly if the PDL is inflamed. If a periradicular abscess or acute inflammation was present, the tooth may be also raised in the socket. Because of the pus accumulation, there would be a vertical mobility and raised feeling of the tooth in the socket. You must exclude increased mobility because of existing periodontal disease or a root fracture or recent trauma or any other premature occlusion contact. A premature occlusion contact would mean traumatic occlusion, and trauma from occlusion, along with giving you apical periodontitis, also gives you hypermobility. Then periodontal probing should be performed to detect any loss of attachment or exposed dentine. Dentine hypersensitivity usually would not give you such severe and long-lasting pain, so we are not even considering it as your differential diagnosis. But however, some pocket or a previous periodontal treatment history could have exposed a lateral canal or canal invocation, which allows bacteria access to the pulp. What does that mean? That it could mean that it was primary periodontitis and could have become a secondary endodontic involvement, because this tooth doesn't really have been exposed with caries as of now. So there is a possibility that the secondary involvement of the pulp could have taken place through the exposed dentinal tubules, and that would be known as what? If this condition is found, the pocketing leading to involvement of lateral canal, this is your concomitant disease. And how would you classify it? Because of an existing primary periodontal disease, a lateral canal got involved. So it's primary perio, secondary endo condition, right? And no matter whatever these concomitant disease are, the treatment would follow first endo. And because it was a true standing periodontal disease, it would require periodontal debridement as well, right? So first endo treatment and then periodontal treatment. I hope you've been following the Voltaire's concomitant disease references and learning and grasping that concept as well. Because it has never been asked directly, but because in the exam now ADC is giving you multidisciplinary questions, so it's a very hot topic for ADC. So I cannot emphasize enough. Please make sure with your study partners you are revising the concomitant diseases as well, because perio leading to endo and then endo leading to perio, that's a multidisciplinary approach, right? Different problems leading to another problems. And that is the ADC's favorite. So that's why you know how important that concept is. I have taken that already with you in the endo class. You can watch that recording as well to revise the concept and also read it from Walton to reinforce the concept. Now, search for a sinus. That would indicate that periradicular infection is present or a chronic periapical abscess is present. Sinus can heal and can also present as a small fibrous nodule, indicating a past or intermittent infection. Search must include even the lingual side of the mucosa, because the apices of the lower molars, they lie closer to the lingual cortex than the buccal cortex. So on examination, you find that there are no mobility, no tenderness on percussion, or any apical tenderness. There is no detectable sinus also. So that means there is no periapical involvement yet, no periapical abscess yet. That means the inflammation is only confined to the pulp as of now. And there is also no adjacent periodontitis, which is present. So that means it's a true endodontic condition, primary endo condition, not coming from a primary perio disease. And also it's still confined within the pulp, has not got its any periapical involvement, right? Diagnosis, I assume, makes sense with all those findings. What are those investigations indicating? What the periapical status means? What is the sign and symptom in the periapical status means? I hope all have been discussed with you in the class, and I really hope with this revision, it all sums it up together in limited words, in few words, right? Also your endodiagnosis article. So I assume now with the endodiagnosis article and with this case, and also the discussions in the classes, it's all coming up together and it's shaping up so well that given any kind of pain and any kind of sign and symptom provided to you from a tooth, you would be able to identify the cause, the etiology, and the diagnosis, right? I totally assume from you now that you should be able to come to the endodontic diagnosis without any problems. So what investigations would you perform? So first would be, now because you suspected and made a diagnosis, you also need to confirm your diagnosis. So that would be done by the pulp testing and also with a periapical radiograph. So pulp sensibility are required to increase confidence in your assessment of the status of the pulp. EPT or thermal testing are available, and use of a stimulus that usually provokes the pain is recommended. Ensure that healthy adjacent, opposing, and contralateral teeth are also examined to obtain a reference measure for the patient's response. So the control teeth are being used here as adjacent, contralateral, and also opposing teeth. If tests yield equivocal responses, a test cavity without local analgesia should prove conclusive. So when there is an equivocal response or something that is not leading to any conclusion, in that case, what is the best test that suggests the ideal or the actual pulp status? The best test or the most accurate one is always test cavity, which we have discussed also in the class. When all the options are given, the most accurate one is test cavity. Amongst the pulse sensibility test, the cold test is the best one. But whenever test cavity is given, that is the most accurate one, right? So if all the pulse sensibility tests do not give you any leading results, then the test cavity is the most conclusive one, right? Because you're not using any LA and you start drilling into the tooth. If pulp was vital, definitely it would bleed, it would pain. And if it's no analgesia and you're drilling, there is no bleeding coming from the pulp or there is no pain in the pulp, then that would indicate that it's a non-vital pulp, right? A periapical radiograph of the molar teeth is required. That would give you the periapical status and also the caries status of the tooth. So what are the limitations of test of sensibility? So this you have also read in pulp neurophysiology article, and here in fact it's a summary of what it means to conduct a pulp sensibility test, which means that they do not really truly measure pulp vitality, and they are a misnomer, and that is why they only test a sensory nerve pathway from the pulp to the brain. For this reason, they are referred to as sensibility tests, and they're not true vitality tests. So that's a misnomer when you call them the vitality test. So it is assumed that pulp without sensory innervation is devitalized, but this is not necessarily so. Inflammation can alter some sensation, and sensation may be incorrectly localized. Conversely, a positive response also does not guarantee that it's a healthy vital pulp. Tests sometimes indicate a hypersensitive pulp, and this is more useful piece of information because detection of hypersensitivity is not prone to false positive or false negative results. Now, what are the causes of misleading electric pulp test result? So both false positive and false negative sensibility responses can occur. False positive means that when you get a response from the pulp indicating that it is vital, but truly it is a degenerating, irreversibly inflamed or necrotic pulp partially. False negative means that pulp does not show any response to these tests, and you would assume that it's a non-vital pulp, but in fact this was a vital pulp. So together with precautions it should minimize the risk of a spurious result, and they're listed in the table. We'll go to the table again. On performing the test, when you perform the vitality test for this patient, you discovered that the lower second molar gives a hypersensitive response to a hot GP, so it gave a positive response. The pain lasted until an LA was given. So because it was irreversibly inflamed, it did not subside on its own in a while. If it was a vital pulp, upon stimulating with cold or hot, there would be some sensation, but then it would subside on its own within a few seconds. But because it was irreversibly inflamed, you only had to give a local anesthesia to subside it. Otherwise, it was a prolonged pain. So it confirms the diagnosis of irreversible pulpitis. Now going to the table 47.2, which tells you what are the reasons for false positive and false negative. So why is EPT more likely to give you false positives or false negatives? The cause of error first, we're discussing why it can give you false positive response. False positive means that you're getting a response, but it's actually an inflamed pulp or a non-vital pulp. So if patient's anticipation of pain or sensitivity. So test the control teeth first, several times if unsure, and raise the tester level setting slowly and incrementally to reduce and work around this kind of error. Sometimes you can get that error with the fact that in multi-rooted tooth, one or more canals can contain necrotic pulp tissue, and in the remaining canal, you can still have vital tissue. So you can get a false positive from that remaining healthy canal, but overall pulp would be inflamed and would require RCT, right? So it is a false positive. And the work around it is that test at several sites over each root on exposed dentine if possible. Then the other possibility is that sensation originates from gingiva rather than the tooth, truly. So it's a false positive again. Make sure that teeth are dry. Keep electrode away from the amalgam restorations, which extend subgingivally so that they do not conduct the current to the gingiva. Other reason is that sensation can arise in an adjacent tooth, and because the tested tooth is not electrically isolated, again, avoid it by keeping the electrode away from the amalgam which contact the adjacent teeth. Dry the teeth, isolate teeth, and then other possibilities that the C nerve fibers within the pulp tissue can still function. So A delta has died, but C fibers are still there, and for some time after loss of their blood supply, but you cannot work with it. You will still get response, but that would still mean that it's a non-vital or a degenerating pulp. You cannot work around it, but that is the reason for a false positive. What is the false negative reason? False negative reason is that there was not a proper contact between electrode and tooth, so you did not get a response, but actually that pulp was vital. So make sure you use a good contact surface area, use conductive jelly to couple the two surfaces together. Other reason is you gave an inadequate electrical access to the tooth tissue because of insulating non-metallic tooth coverage. So if it was a capped or a crown tooth, right? We have done that question. There would be no circuit completion, and you can't work around it unless the restoration is to be replaced, and you can cut out the crown and then put it on dentine. But if it is a crown, then you put an electrode, there will be no completion of circuit, and you will continue to have a false negative response if it was truly a vital pulp. So it is contraindicated in a crown tooth. Then advanced age or pulp insulated by thick physiological secondary dentine deposition. So now this is in addition to what we have been discussing in the class. So there is this change of the concept that I would like you to make note of. So where there is pulp chamber reduction in size because of the secondary dentine deposition, and in aged patients, the pulp chamber size reduces. In that case, EPT is not helpful. Then the cold test is effective. EPT is helpful in the calcified canals. Not for the calcified chamber, but a calcified canal. So I think in the class we have done the calcified chamber. EPT is best in aged patients, so please make that change. In the advanced age or chambers reducing in size, the cold is preferred. EPT will not work. You cannot have a work around it also. But calcified canals, where the pulp chamber is still intact, EPT is preferred. And the reference for the same, you will also find that EPT is preferred for calcified canals. You will find it in your endodiagnosis article. I will share the screenshot after the class also on that, so you can cross-check as well. So thick secondary dentine and calcified pulp chambers, EPT is contraindicated, but calcified root canals, EPT is indicated. And a recently traumatized tooth also, EPT is indicated, right? So the indications of EPT would be a recently traumatized tooth and also your calcified canals, not calcified chamber, right? So make that change, please. Then heavily restored or worn tooth with a pulp which is insulated by a thick reactionary tertiary dentine deposit. So again, a calcified chamber, here it would not be effective. So either you can place electrode close to the root canal rather than occlusion, and if this is suspected. Then higher pain or sensation threshold. If the patient has higher pain threshold, he would not give out any response, but that would not mean that his pulp is dead. So it is a false negative. But there is no work around it, but usually that's not a problem. So these are the reasons why EPT can give you false positives or false negatives and how you can avoid them and work around them. So now, on performing these tests, you discover that the lower molar gave a hypersensitive response to hot GP, and it lasted until an LA was given, confirming your diagnosis of irreversible pulpitis. The periapical radiograph of the second molar is shown. What do you see? So the left molar shows extensive radiolucency under the existing radiopaque amalgam restoration, which is also touching the pulp horns now, which is your secondary caries. And there is no obvious periapical radiolucency. That means it also correlates with your clinical signs and symptoms of no periapical involvement. And an impacted mandible third molar is also visible along with the intact borders of inferior alveolar canal. So let's look at the radiograph also. Now this is your inferior alveolar canal, which is corticated, intact borders, and the periapical area in this root seems normal. And this is your amalgam restoration. And now underneath there is a radiolucency involving the both pulp horns, and it's a deep secondary caries involvement. So 8 months ago, it would have been a smaller involvement, smaller caries, and pulp was reversibly inflamed. In those 8 months, it continues and it encroached the pulp, and now it has been irreversibly inflamed now. So the diagnosis is irreversible pulpitis in the lower left second molar tooth caused by the large caries lesion. When the pain started 8 months ago, caries lesion would have been smaller and the pulpitis would have been reversible. If it had been treated preventively and operatively at that stage by the oral healthcare team, then the likely endodontic treatment would have been or not required. So you could have prevented it if it was saved in time, right? Now, what emergency treatment would you provide at the first appointment? Now, this also ADC asks you a lot of time. What is the emergency treatment for irreversible pulpitis? So the ideal emergency treatment for irreversible pulpitis is actually the pulp debridement and giving an intracanal dressing. And preferably the dressing is calcium hydroxide. We have discussed that. The best irrigant is sodium hypochlorite as per the article that I've given you, and best dressing is calcium hydroxide. Now, the other question form that ADC asks is what is the minimal emergency treatment of irreversible pulpitis? Now, the minimal word here makes all the difference. So that means that not a complete emergency, but what can be done minimally to at least relieve the patient of symptoms. And the answer for that is pulpotomy. So also I will share this reference after the class from the Walton as well, that pulpotomy is the minimally accepted emergency treatment. It's also mentioned here in the Odell's. There is one reference here as well. I'll share from the Walton also. So the caries lesion is extensive in the second molar, assuming the tooth is to be retained and conserved. The first priority is to relieve the pain. Having assessed the pulpitis as irreversible pulpitis, extirpation of the pulp is the only appropriate treatment, and this will require cleaning and shaping of root canals to ensure that no remnants remain. Extirpation with a barbed broach alone risks leaving a fragment of inflamed vital pulp that could cause pain after treatment. A root canal dressing of non-serine calcium hydroxide will inhibit bacterial growth. This must be sealed from rest of the mouth with a suitable provisional dressing material to prevent bacterial ingress, and then pending definite treatment. Now the mention of the minimal emergency treatment is also given here. So pulpotomy, where you only remove the coronal pulp, or partial pulpectomy with the removal of pulp from the widest canal, is sometimes advocated in multi-rooted teeth, but should be avoided. So they say it with a little bit of cautious that it should be avoided, but actually it is the minimal emergency treatment. It is an accepted minimal emergency treatment. It may not be ideal. That's why when I said, if they ask you the ideal, then you go with the complete pulp debridement. And this is a minimal, then pulpotomy is accepted as a minimal treatment for emergency treatment of irreversible pulpitis. The apical extent of inflammation in the pulp is unknown, and the pain relief cannot be guaranteed, but some pain relief can still be achieved with pulpotomy as well. So when ABC asks you this question, what is a minimal emergency treatment, then pulpotomy is actually accepted. It may not work all the time, so it is an accepted minimal emergency treatment. What definitive treatment does the patient require for the second molar then? Well, the patient should return for cleaning, shaping, and obturation of the root canal, and a definite canal restoration. A cuscal coverage indirect restoration, either you go with an onlay or with a full coverage crown, it should also be considered for protection against the occlusal forces. Post crowns in molar teeth are to be avoided because of the incidence of perforations and root fractures. Retention is sufficient usually from the undercut shape of the pulp chambers and the remaining coronal tooth structure. After discussing the possibility of restoring or extracting, the patient goes for RCT. All options, including the normal advantages and disadvantages of each, needs to be discussed and conveyed to the patient. These conversations need to be fully documented in the notes and time given to the patient to understand the responsibility and consequences of the care provided. By managing patients' expectations at this stage, a later medical legal issues can be avoided. You carry out the first stage of treatment successfully. However, the patient fails to return to complete the treatment. When he returns after 6 months, you discover that the tooth has remained asymptomatic, but the coronal temporary restoration has been lost and the lingual cusp has fractured off. The pulp chamber is open to the oral cavity, but the tooth is still restorable. So what effect is it going to have on the long-term prognosis now? Now it has no coronal seal and it is also fractured off. Well, the loss of coronal seal has allowed the microbial invasion of the root canal and dental tubules. Bacteria and their metabolic products are irritants. They can penetrate apically along the lateral canals and can maintain periradicular inflammation. In addition, flora in the canal has also changed now. It has become more of a mixed flora, with anaerobe becoming the predominant species in the canal. And this may be more difficult to eradicate and is more likely to penetrate through the apex and induce an acute abscess. Fracture of the cusp has further weakened the tooth, and it can complicate the building up of a core to support a definite coronal restoration. But you still go ahead and complete your RCT. So what should be the next stage? So root canal must be recommenced as soon as possible. The tooth should be isolated with rubber dam. Root canal should be re-cleaned and reshaped with use of appropriate files. Copious irrigation with sodium hypochlorite. Sodium hypo is antibacterial, but some bacteria can still survive in lateral canals and dental tubules, which are blocked by the smear layer. And that's why the smear layer is removed by occasional irrigation with EDTA. We have done this question as well, right? That what removes the smear layer? Where they're given separate options, EDTA and hypo separately. EDTA alone removes the smear layer and then helps the sodium hypo to penetrate the dentine and the lateral canals. So it is important that the coronal root canal preparation is carried out first to reduce the bacterial load. That's why the crown down technique is preferred one. Although some can do the step up technique, but these days the preferred technique and the most coming out with the best prognosis is your crown down technique, which involves the preparation of the coronal third of the canal first and then going to the middle third and the apical third debridement. So that actually helps in good irrigation and prevents the pushing away of the pulpal remnants into the periapical area, right? So the GP master point trine radiograph shows multiple curvatures of the mesial canals as shown in the pictures. This was a trine and it has achieved complete and sufficient fill here. How long should this be monitored after completion of RCT? What are the criteria for success? So root canal should be reviewed after 1 year, as suggested in the guidance of European Society of Endodontology, and outcome must be evaluated clinically and radiographically both. Radiographic assessment must be made by comparing the appearances of the previous films, taken under conditions that are near standardized as possible. So best way would be to take with the paralleling view. That is the most standardized and about to give you the most accurate results. Now the criteria for success and failure are given here. So the success would mean that there are no symptoms, no tenderness on percussion or increased mobility. There's no sinus, width and contour of PDL are normal. There is slight radiolucency if it was overfilled, but there should be no symptom associated with that. Then uncertain or questionable prognosis would mean that there is no symptom or sinus or tenderness or percussion, but a smaller radiolucency is still left at 4 years than seen on the completion of root canal filling. Some authorities suggest if you see a reduced radiolucency but not completely resolved from the original one, you still continue to monitor it. But there should be no symptoms to still call it a questionable prognosis. It would still not be a failure because it's not symptomatic, right? But radiolucency still exists, clinical symptoms are absent, so it is a questionable prognosis. Complete failure would mean that there is symptoms also and there is radiographic changes as well. So either enlarged radiolucency or a new radiolucency. So sign and symptoms plus radiographic changes is failure. No clinical symptoms but radiographic symptoms still present is questionable, and completely resolved radiographic lesions and no sign and symptoms is absolutely complete success, right? So you can divide in clinical and radiographic sign and symptoms. So here both are negative, here one is positive, one is negative and the other is positive. And in failure, both are positive, right? That sums up. Makes it easy to identify. If you're given a history, you can simply check the clinical and radiographic symptoms, both negative, you mark it as success. One is negative, one is positive. It's a questionable prognosis. Both are positive, it's a failure, right? I hope it solves the doubt and clears all the air around the endodontic diagnosis and also your treatment part. All right, let's start with case 48, or case 49. So case 49, a swollen face. So we'll be learning and reading about various kinds of swellings and facial swellings, learning about some of the superficial spaces, some deep spaces, and an odontogenic infection spreading and involving your facial spaces. What should be the management, identifying which space is involved, and what is the treatment protocol, antibiotics, and everything around it will be discussed in today's class. So a 30-year-old man is referred to your dental hospital by this general practitioner with a painful swelling of the right side of the face. What is the cause and what treatment would you provide? So when you look at it, the swelling spread is seen on the right cheek, which is not involving nasolabial angle, although this fold is not obliterated, it is more on the cheek, and it is going towards a little bit of towards your eye. The patient has had toothache intermittently for many months. A few weeks ago, the pain became excruciating, stopped responding to analgesics as well. Then suddenly it reduced in severity and patient thought it had resolved. Now reading these 4 lines only gives you the complete progression of endodontic diagnosis. So it was intermittent tooth pain, right, for many months. Let's call it was reversible pulpitis. A few weeks ago, it became excruciating, severe, and also stopped responding to analgesics. That means it went to irreversible pulpitis. And then it suddenly reduced in severity, and patient thought that it had resolved, but what had really happened, it had become completely necrotic, so all the nerves had died, and it is a necrotic pulp now. So that is the progression of the pulpitis and the tooth infection, endodontic diagnosis progression. However, about 10 days ago, a different pain developed. A tooth on the upper right had become very tender and he had not been able to bite on it. That means with the necrosis, now it had developed the periopical involvement. So necrotic pulp 10 days ago involved the periopical area because he was not able to bite on it. And then suddenly a swelling enlarged yesterday. That means that apical periodontitis now becomes a swelling has come. So it has become a periopical abscess. And then periapical abscess has also involved the facial swelling now. So facial space has gotten involved. So the periapical abscess, which was localized infection, has now spread to a facial space, right? It has become a spreading infection. We'll call it a spreading infection. When if it's totally within the bone and or seen as a swelling in the sulcus, it's a localized odontogenic infection, right? It would be a localized odontogenic infection till the time it is within the confinement of bone or in the soft tissues in the mouth. Once it progresses out into a facial space, we will call it a spreading infection. Now, the old 2012 TG uses the terminology of deep space infections and the superficial space infections. So it has divided the spreading infections in 2 kinds. One which involves the maxillary spaces, which are called your superficial spaces, like your buccal space, intraorbital space. And one are your deep spaces, which is closely in connection with the respiratory spaces, which is your submandibular, sublingual, or submental spaces, right? So the 2012 TG divides it in the basis of areas, location. Deep space and superficial space, both are your spreading infections, right? Just like here as it has become. Over the last few months, the patient has been prescribed several courses of antibiotics and finished a course of erythromycin only 2 days ago. Patient is otherwise fit and well. The patient is shown in the picture, and the swelling is hot, tender, and firm centrally, but peripherally, it is almost painless and softer. It extends from the nose to the anterior border of the masseter. Lower eyelid is very edematous and contains blood pigments as if it's bruised, like here. This is the lower eyelid area. And the swelling is not pointing extraorally. There are palpable tender lymph nodes in the upper deep cervical chain. So that is also a characteristic feature of a spreading infection, that the lymph nodes get involved because it involves the facial spaces and they drain into the lymph nodes. So the lymph nodes get involved. Patient has slight limitation of mouth opening, that is a mild trismus, but it does not significantly hamper examination. And the sulcus, which is adjacent to this upper first molar and the both premolar, is tender and it's slightly reduced in depth by a presentation of a swelling intraorally as well. Upper first and second premolars and the first molar have large amalgam restoration, so any could be the source of infection. But because the periapical area is involved, it's a well localized infection. The patient is easily able to tell and localize the tooth and tells it the second premolar where it hurts on biting and is the cause of pain. And this tooth is slightly mobile and raised in its socket, which we learned in the last chapter also, that whenever there is an abscess or pus accumulation, there would be mobility and feeling of raising the socket. You apply that concept here. See how everything is interconnected when you study it all together. It is very tender on percussion and also will be non-vital because you see that it had gotten necrotic also. So there would be complete damage to nerves and blood supply now. So there would be no response on pulse sensitivity test, which would be a cold test. In this case, a first molar and the first premolar appear vital. So second premolar is non-vital and the source of infection. Now, which additional investigation is critically important and why? So you would take the patient's temperature, and this gives a good indication of the systemic effects of the infection and reflects the amount of pus in abscess or the tendency of the infection to spread. Now, in this case, the patient's temperature is 37.2 degrees Celsius. Now, the new TG has actually divided the spreading infections in 2 categories. The old one has divided in the category of spaces like deep infections and the superficial infections, right? Based on what spaces are involved, the submandibular and pharyngeal spaces come into the deep space infection, and your buccal space or your intraorbital space come into your superficial space infection. Based on the 2019 version, they have divided it as spreading infection with severe or systemic sign and symptoms or spreading infection without severe or systemic sign and symptom. So the old TG says, if it's your superficial infection, you do the active dental treatment and oral antibiotics. If it's your deep space infection, you do the active dental treatment, hospital admission, and IV antibiotics. So I'm giving you this quick review. Superficial space infection, you do the active dental treatment and oral antibiotics. For your deep space infections, hospital admission, active dental treatment, and IV antibiotics, because they are highly risk-oriented and there can be a risk of respiratory asphyxiation. So hospital admission, IV antibiotics, and active dental treatment. Now the 2019 version says both are spreading odontogenic infections no matter whatever space is involved. No matter whatever space is involved, superficial or deep. If you see severe or systemic features, or if you don't see your severe or systemic features, based on that you will decide. So without severe or systemic features, do the active dental treatment and oral antibiotics. But with your severe or systemic features, do the active dental treatment, but in hospital admission and IV antibiotics. So what was for superficial in the 2012 is now for the spreading infection without sign and symptoms. What was for deep infections in the previous one is now for your spreading infection with sign and symptoms. And what are the sign and symptoms? So severe features of the spreading odontogenic infection include significant facial swelling and pain, trismus, swelling of the neck, difficulty swallowing, and difficulty breathing. These are your severe features, and severity. That indicates that it's a severe one. And the systemic features will include elevated temperatures, pallor, sweating, tachycardia, the systemic signs, right? Now, this person has 37.2, only mild trismus, it is not affecting much. So it is mostly towards the not so severe or not so systemic features. But as per TG, above 38 degrees Celsius, you would have your systemic involvement. And if it was systemic involvement and severe involvement, then hospital admission, active dental treatment, and your IV antibiotics. If you remember the criteria like this, it becomes so simple to immediately know the treatment protocol, right? I hope it helps you, gives you the contrast, and there is still a connection. It's just that how you look at it. So they have stopped looking at it like the spaces, but they have rather started to look at it like how severe and systemically involved it is. They're not concerned with the space now. Earlier they used to think that the space decides that how severe or systemically involved it can get. But now they believe instead of stop defining it as spaces, just focus on the existing severity signs and the existing systemic signs, and that decides your hospital IV or oral outdoor patient. Easy peasy, nothing complicated, easy to put it into perspective. And now, any case you get, any swelling you get, whether you're taking in March, whether you're taking in September, whenever you're taking, whether you're following 12, whether you're following the new one, you can easily identify the case now and easily manage the protocol of management, right? Now, Odell has given a slightly different management. Of course, if this particular case was in the ADC exam, you would be following the TG recommendation. So wherever there would be difference in Odell now, I will highlight that and I'll remind you of what TG says and we will follow what TG has to say about it. Now the regimes are absolutely same in the 12 and 19, the IV regime and the oral regime. And as I told you, what you can do, write down, if you're taking the exam, and if you're following 12, write down the superficial space infection regime and then write down the deep space infection regime. If you're taking from 19 version, then you write down spreading infection without sign and symptoms or spreading infection with sign and symptoms. And below that, you write these regimes of IV. You just have to, when you write it for you don't have to write patients requiring intensive care support or not requiring intensive. You simply write either 2.4 grams or 1.8 grams 4 hourly, and plus you will give metronidazole 500 mg IV, which would be given 12 hourly. So if you write down, I'm giving it BD, I'm giving it PDS, it would be easier for you. So you write it down, write the number 2.4 grams, 1.8 grams. Remember, for the next 4 months, if you look at 2.4 grams, 1.8 grams, and 500 mg IV, who cannot remember this if you continuously look at it for the next 5 months, right? If I've given you this method of putting all the regimes of TG on the areas that you look at every day and you write it nicely and boldly under characteristic headings, how can you not remember these numbers? Easily, right? That's how easily it will get for you. So now let's see what Odell says and explains. There's still a lot to learn from Odell. Let's go back to it. Only the management and the antibiotic part is slightly different. Otherwise, everything is wonderfully given here in Odell, which is totally applicable to Australian treatment management as well. So which additional investigation is critically important and why? So you would take the temperature because it would tell you, in fact, the management and systemic spread. In this case, it's not much systemically spread yet. There's not much trismus and the patient doesn't have any pallor or any other tachycardia. In this case, radiograph, would you take a radiograph? Well, for this particular patient, it would not be a useful investigation. If it was a long-standing necrosis, because here the necrosis only happened few days ago, right? Only 10 days ago, this patient had got a necrosis and the periapical involvement had occurred. That's why it takes at least 3 weeks of the establishment of periapical infection to show it on the radiograph. So it has happened only about 10 days ago. Only in this case, it is not helpful. But otherwise, if you have another history where there is this periapical, maybe they tell you that there was an intraoral swelling on the sulcus from last 3 months, then would the radiograph be important? Absolutely yes, because you would see periapical radiolucency there. But because only here it is 10 days ago, so it would not be helpful in identifying a periapical diagnosis. So only in this case, because it's so soon and it's an immediate spreading infection, it is not a helpful investigation. But otherwise, for periapical infections and swellings, is the radiograph not important? Yes, it is. The only case why they're answering no here is because of this particular window of less than 3 weeks, which would not be applicable to all the histories in the exam. So you have to keep your eyes and mind open that does the radiograph saying no to a radiograph is applicable here or not. So they're saying here no for 2 reasons. One, that it is only 10 days old, and other is because it's in the maxilla. So these roots would be obliterated by the maxillary sinus and can be confused as a swelling, which would not be expected at this point. That's all. That is all. Otherwise, a radiograph is important when you have a spreading infection. So in this case, only in this case, radiograph is not a useful investigation. Tests of vitality are more likely to identify the causative tooth, and in any case, there appears to be no doubt about the diagnosis. They did anyway took the radiograph, and you see that the second premolar, the lamina dura is completely intact, and the PDL is completely of normal weight, so there are no changes as expected, right? And however, there are good reasons why taking a radiograph may not help or even actually be counterproductive in this particular case. It takes up to 3 weeks for radiographic changes to develop at the root apex after pulp necrosis. The radiographic features can be misleading if you attempt to use them to diagnose loss of vitality. When root apices are radiographed with the maxillary antrum superimposed, the normal PDL can appear wider, and that can be confused with the apical changes. But these problems are seen in this radiograph, and periapical radiograph of this patient is completely normal. Now, what do these findings tell you? There is a combination of inflammation, there is a non-vital tooth, and an adjacent probable abscess, which indicates an odontogenic soft tissue infection. So there is definitely an abscess, but only radiographic changes are not seen on the in the bone. But the bone absolutely has pus circulation, but it is not damaged to the extent that it will show on the radiograph, right? So abscess is definitely there. And now that abscess has actually started to drain into a facial space, and it's no more a localized infection, right? Now the history of severe toothache that has suddenly resolved suggests that it was pulpitis, that subsequently became necrotic. I explained that sequence, right? Now the subsequent pain of a different character, which started as an apical abscess, that was also explained. Patient points clearly to the second premolar. It becomes a well-localized pain once the PDL gets involved. That is also explained to you. Makes sense, absolutely. Every sign and symptom is telling a story, and now you have the tool to read that story and comprehend that story. You can make out the meaning of every sign and symptom, every way the sign and symptoms are progressing. Do you feel you are equipped now to read the sign and symptoms, to understand their progression, derive the meaning what's going on without anybody having to tell you the etiology and diagnosis? This is what you're aiming for, to flow with the endodontic diagnosis and knowing it so well that you can totally understand, totally know the meaning out of it, just by looking at the history. That is what you want to aim, the caliber you want to take to the exam, and then you will master all the endo questions being given to you. If you achieve this acumen, if you achieve this skill, nobody can stop you in performing amazingly at part 1, paper 1. Right? So now this week, when you take the endo quiz also, you will realize how much you have gathered from endo. It would be so much fun taking the endo quiz, seeing your levels in the first attempt, and do not fail to apply learning from your mistake formula, okay? So you can improve your scores amazingly well. Now, trismus is an important sign indicating that infection or inflammation has spread to involve the muscles of mastication. However, trismus is not severe and probably results from inflammation and edema of the buccinator and anterior fibers of masseter, which lie at the posterior border of the swelling. Infection has induced minimal systemic effects. Patient is not significantly pyrexic. Infection appears to be localized, so it is not showing severity and not showing systemic involvement. If I talk in terms of 19 TG, right? The firm center to the swelling and swelling in the sulcus will contain pus. What type of soft tissue infection arises from the teeth can cause you facial swelling, and how may they be distinguished, and what is the relevance of doing so? So facial swelling may be the result of edema, abscess formation, cellulitis, or the combination of any of these. So let's see what are these three different kinds of swelling, what are their features. So it is important to determine what type of infection is present because the treatment and the sequelae of all these three kinds is different. Abscess requires drainage, cellulitis requires aggressive treatment like hospitalization, IV antibiotics. Edema usually does not require any direct treatment or in fact any antibiotics. It just requires the removal of the cause of infection or inflammation and usually subsides. Despite the fact that the use of terms mentioned above is convenient, but in practice most of these infections are mixed flora and they would not be like confined to one category alone. There would usually be overlapping zones. And which type of infection developed is determined by the virulence of pathogen, also the resistance of the host, and anatomical constraints of the infection. So edema is usually a soft swelling. It is not very red or hot. It is not tender on palpation also or painful. It just has inflammatory fluid accumulation and it is compressible with slow continuous pressure, and it often accounts for much of the facial swelling in children usually when they develop odontogenic infection. Abscess, whereas, is a localized collection of pus which can feel hard, dense, and would be covered by thick layer of tissues, can sometimes be softer also and be fluctuant, and it can be pointing to the skin or mucosa that would indicate abscess is there. There is pus formation. Cellulitis, whereas, is brawny, poorly localized swelling, and with marked tenderness and dark red maroonish appearance. It can contain also small abscesses within it, but not a large localized abscess, but small collection of pus. And then it can spread also sometimes, but very rapidly through tissues, and usually would be associated with systemic symptoms like fever, malaise, and elevated WBC count and lymph node involvement, right? Now, if the infections are not easily characterized, what should be the features on which you will base your treatment? So now, the critical factors that must be determined are whether the abscess cavity is present. You will palpate and see whether it's a palpable fluctuant abscess, or if there is a systemic sign and symptom, or if it is rapidly spreading. So the severity and your systemic signs, which is given by your TG, you would apply those factors to determine what kind of treatment would be required, right? You're not worried about what Odell says. We have the criteria by the TG. We will follow that. The patient is predisposed to infection or has any immune compromised situation, then also. So what type of infection is this? Well, this is primarily an abscess and also surrounded by some amount of edema. What has happened, the premolar, if there was a periapical pus formation, when the periapical infection spread, either it could go to the maxillary sinus, or it could go in the palatal mucosa and give you a palatal abscess, or it can go into the buccal sulcus and give you a periapical abscess in the buccal sulcus, or it can go above the muscle. This is your buccinator muscle. If it remains below the muscle, it would remain, the swelling would be into the sulcus only. But if it travels above the attachment of the muscle, and this is between skin and the muscle, if it travels between skin and the muscle, what would happen? What has happened to this patient? That will happen, right? A facial space swelling. So in what tissue space is infection tracking or localizing? What are the boundaries? So this appears to be in the buccal space. It is a potential space between the buccinator and the facial muscles and the parotid fascia, filled normally with a loose connective tissue. Posteriorly, the boundary of this space would be the masseter muscle, and around the front of the ramesh to the pterygoid space, and edema spreads beyond the buccal space to involve the lower eyelid and the anterior canine fossa. So this pus may be still in the buccal space, but the edema is also spreading to the infraorbital space, right? The abscess is not yet pointing to the skin. Now, why has the infection localized here, and will it remain localized here? Well, abscess, which is arising from the canine, premolar, and molar, can perforate the buccal plate of the alveolar bone and can spill out into the soft tissues either above or below the attachment of buccinator, as I showed you on the diagram as well. Now, the attachment of the buccinator usually runs below the apices of the upper teeth, so the infection is likely to remain, pass superficially to the buccinator, and go into the cheek. If it passes below the attachment, it will develop an alveolar abscess within the sulcus. If it passes above, it will become a facial swelling, right? Now, despite being a thin muscle, buccinator is a significant barrier to the spread of infection. It is unlikely that infection would be able to perforate the muscle and develop a sinus into the mouth. Several sequelae are possible. Pus can gravitate even downwards and go to the lower border of the mandible, can also involve submandibular space. It can go back and break the masseter muscle and can involve the masseteric space, even an intratemporal space. It can also spread to the infraorbital space. So there are so many continuations and merging boundaries, so it can actually spread to various other spaces as well. Is it potentially life-threatening infection right now? And if so, why? So not yet. In this case, it seems localized in the buccal space. Spread is not very rapid because there are no systemic symptoms, and the infection spreads more. If it spreads more, then the situation would change. Because of the involvement of eyelid, and there is edema already, and if it goes on and the pus also travels in that space, then the infraorbital space communicates with the cavernous sinus thrombosis, cavernous sinus, and there would be a risk of cavernous sinus thrombosis. This is a very rare but a potentially fatal complication. So it's not a very common complication, it is rare, but when it happens, it can be fatal. It would also be possible for infection to spread posteriorly into the pterygomandibular space, infratemporal fossa, and all these spaces are connected with brain, either through the cavernous sinus or through the middle cranial fossa, through the direct veins, which have no walls as well. So there can be complete communication of these spaces and the brain spaces, cavernous sinuses, and that infection can involve the brain and can turn fatal immediately. So how do you identify that a cavernous sinus thrombosis has occurred? What would be the feature so that at least you cannot ignore or miss out on this important consequence? So the thrombosis of the cavernous sinus results from spread of odontogenic infection along the two main venous pathways. Bacteria and infected emboli travel posteriorly from the upper lip and face via the anterior facial vein. This connects via the ophthalmic veins to the cavernous sinus without walls, which might otherwise prevent this retrograde flow. Alternatively, infection can spread from pterygoid space via the pterygoid plexus of veins, which connect directly to the cavernous sinus via foramen ovale. You don't have to learn this much of anatomy, but remember that these spaces can totally drain into the cavernous sinus and infect it, and can lead to thrombi. So the local features are seen on the side at first, but then it becomes bilateral as the thrombus grows. Features are that there will be marked edema of the eyelids, pulsating at the exophthalmosis caused by venous obstruction, a dilated facial vein, inhibition of movement of the eye, papilloedema, retinal hemorrhage, and rapid pulse, marked pyrexia, and severe malaise as a systemic effect. So in addition to the treatment of the infection, anticoagulation would also be required for the thrombosis formation, and the mortality rate is extremely high. So treatment at the right time with correct protocol, as mentioned in TG, is extremely must to avoid this serious consequence. What are the general principles of treatment for all odontogenic infections for soft tissues? So treatment should be started immediately. Infection can spread quickly, and in some cases, it progresses to a life-threatening situation. Identifying patients with a risk of significant complications, those at risk of airway obstruction or cavernous sinus thrombosis or toxemia, and which present malaise or high temperature should be treated immediately with IV antibiotics and with hospital management. Now, does this not completely relate with what TG19 has to say? If you have malaise, if you have fever, if you have complication risk, if you have severe infection, hospital administration, IV antibiotics, and active dental treatment. Simple. Can you relate to that, everyone? Is that clear? Making sense for everyone, I assume, for now? Okay. Now, pus must be drained as soon as possible. What is the active dental treatment? Active dental treatment is removing the source of infection. Do something to eliminate the infection. What can you do? You can do two things. Remove the tooth or remove the pulp, and IND. Remove the pus, which is the irritant. So IND should be done as soon as possible. With most infections causing facial swelling, the only treatment required is effective drainage of pus and removal of the pores. To ensure success, a drain should also be placed in the incision. Remove the pores as soon as possible. So removal of the positive tooth is either by doing RCT or by doing extraction, depending upon if it's restorable or how spreading it is and how urgently you want to remove it. Mostly in such spreading cases, extraction is the best choice of removal of infection. Then giving antibiotic treatment if necessary. Well, as per TG, all facial swellings are requiring antibiotics. If you look at it, if it's superficial space infection, you need oral antibiotics along with active dental treatment. If it's deep space infection, you need antibiotics which are IV along with active dental treatment. If it's your not spreading antibiotic, or not spreading, not severe or not involving systemic signs kind of spreading infection, then you require oral antibiotics. And if it's your severe and systemic signs involving kind of spreading infection, you require IV antibiotics. So if you look at all the 4 different scenarios given by TG 12 and 19, all of them require antibiotics. Only the difference is one requires oral and the other requires IV. Am I correct? Does that put it to clear perspective? No confusion, no haziness, no blurriness, and you can completely see all the scenarios. That's how quick and confident you have to got to be with your concepts. Am I making myself this clear? How confident, how clear you have to get with each concept. You don't have to spend hours and minutes taking time to think about what I have read in the textbooks. We are not going to remember in the exam what we have read in a particular book. We are going to go in the exam with skills, with knowledge. So we don't have to rely on our memory, but rather on our skills and knowledge. It becomes a part of us that we know everything. It becomes knowing rather than memorizing. So know it rather than to have to think and memorize it. What you have to memorize, prosto will become like endo. Trust me, Dara, I will make prosto just like endo for you. Give it a few weeks. Okay, we've just started on prosto. Now, provide antibiotic treatment if necessary. You know that it is always indicated for facial swellings as per TG, so we are always going for antibiotics here, either oral or IV. We decide based on the clinical signs. Then give supportive measures like good fluid intake, rest, wherever there is hospital administration, analgesia. Then provide progress regularly. So if you are giving oral antibiotics and doing it as an outdoor patient, then you have to review in 48 hours. But if you're putting that patient in hospital admission, IV antibiotics are going, then definitely they are at a regular review, definitely. But remember, the review time for an outdoor patient would be your 48 hours. You have to review them in 48 hours. What are the principles for obtaining drainage and how will you drain the pus? So the principles of IND are, you don't have to memorize it. ADC has not been asking you the IND surgical process. I'll just briefly take you here. So take the anatomy into account, avoid incision near anatomical structures which are important. Incise only when the pus has localized unless rapidly increasing swelling is threatening the airway. So in which case it should be drained as quickly as possible. Incise when the abscess is pointing or at the point of maximum fluctuation. Incise along the most direct route to the pus. If incision does not release pus, deepen the incision by using blunt forceps, not a scalpel, and then use forceps to break open the abscess walls. Then after incision, explore, identify, and open all the locules of pus. Provide dependent drainage so that it is draining towards the gravity. Place a drain if the abscess is large, is deep, or the incision might close before the abscess resolves. Leave the drain in place for at least 12 to 24 hours or until drainage stops. If possible, drain intraorally to prevent facial scarring and skin contraction. On the skin, incise along the Langer's lines or in a skin crease. On the skin, try to incise healthy skin. It will scar less. In this case, the pus lies between the buccinator muscle and the skin. It is not pointing and is palpable in the upper pulpal sulcus. So incision is given intraorally in this case using ethyl chloride spray anesthesia. However, the incision must extend because now you are incising from the sulcus intraorally. So you must incise the muscle so that the pus which is accumulated here can drain out from the intraoral. Does that make sense for everyone anatomically? Incision must extend through the buccinator to be effective because you're obtaining the drainage intraorally. If you're doing it extraorally, you don't have to perforate the muscle. You're incising the skin. But to make it less, to try to not create a scar, and because it is seen and palpated intraorally, so it is gravitating here. So you can incise, but you have to penetrate through the muscle. Now, should drainage ever be delayed? Occasionally, sometimes you can delay it if you want to localize it, and you can wait a day or so by providing antibiotics so that it can localize. Therefore, such a decision must be carefully considered. Will a drain is required? Well, quite probably. Abscess is not very deep, but the incision should pass through the muscle. However, drainage will be dependent. Incision is being made below the pus. Gravity will favor the drainage. It may not always be possible to decide in advance, but if pus drains freely on incision, and it would be sensible to place a drain, preferably you can put a strip of corrugated rubber dam or a gauze. This should be sutured to the edge of incision to prevent displacement. In this case, the drain would be as easily placed under the local or general anesthesia. Now, can the tooth be conserved after the soft tissue infection, and how might you remove the tooth? So the soft tissue infection does not mean that the tooth has to be extracted, and almost all teeth could in theory be preserved. However, most such cases arise as a result of neglect, and tooth is sometimes badly broken down, and then if it's non-restorable, then you better extract it. Occasionally, when the infection is spreading rapidly, or if the airway is compromised, then the tooth is extracted because you don't want to rely on slow removal from the RCT, right? That's why I said in either it's restorable or non-restorable, that decides, or if it's an excessively rapidly spreading infection, then extraction is preferred. So the critical factor is to achieve immediate drainage. Extraction would lead to immediate opening of the socket, which will lead to immediate draining. If the tooth really has to be conserved, it must be opened and drained through the pulp chamber, in addition to the draining by pus by incision also. So ideally, the chamber can be closed again fairly quickly, and as soon as drainage ceases, the pulp chamber can be cleaned and dressing can be placed. If pus continues to drain for some time, then the chamber may be left open for up to 24 hours. After this period, the risk of oral flora entering the tissues increases, which reduces the prognosis of a successful RCT, so that should be avoided. Right? Extraction is the most usual treatment. If LA can be obtained and trismus is not severe, the tooth can be extracted immediately. Otherwise, infiltration anesthesia would be often difficult because of the lower pH of inflamed tissues in the area of swelling. In that case, a block anesthesia would be required. Now, general anesthesia may be necessary. If so, it will be convenient to admit the patient to hospital and complete all the surgical treatments at the same time. GA can take some time to organize, and in the meantime, it would be appropriate to try to extract the tooth under LA. You should never force the jaws open. That will spread the infection. And if the surgical extraction is required, it may be delayed because surgery should be avoided in the site of infection. But now, because of the available effective antibiotics, this rule is an old rule. You can perform immediate surgical extraction also by starting IV line of antibiotics. In this case, anesthesia could not be obtained, so drainage and extraction were performed under GA, and a short corrugated rubber drain was inserted. Now, when should antibiotics be prescribed for odontogenic soft tissue infection? So now I've told you we are not following this criteria, but we are following that any facial infections, right? Any facial soft tissue infection which has drained into the superficial space, we are giving the antibiotics either oral or IV, and we are following the criteria which I just told you on TG. So what microorganisms are giving these soft tissue spatial infections, or these infections are mixed infections, mostly are predominated by anaerobes. So facultative anaerobes are usually present. You don't have to memorize these. And the antibiotics also, you are not going to read from the Odell. You're going to learn the regime from your TG respectively. And I've showed you the antibiotic regime, which is given in the TG. So when it's your oral antibiotic, in superficial infections in 12 version, we are giving either PMP or amoxicillin orally for 5 days, 8 hourly or 6 hourly. And if there's allergy, then we're switching to clindamycin. If it's deep infection, then we are going to your IV antibiotics, which would be metronidazole combined with benzyl penicillin or amoxicillin, right? So as per your 19 version, without severe, you're going with the oral antibiotics. So it would mean metronidazole orally plus PMP or amoxicillin, same. Additionally, you can give a amox plus clavulanate combination, which is augmentin also, which is not given in your 12 version. Then for your IV, you're going with the same benzyl penicillin and metronidazole combination. Same, antibiotic regime remains the same. You have to learn the regime, the dosage, and the intensity or the duration of the therapy. So we're not following this one, but we'll be following the PG1. Now, why to take a specimen for culture and sensitivity testing? Sometimes empirical treatment with penicillin or metronidazole is almost always effective. Sometimes if it fails to resolve, then in that case, it is always wise to take the sample from the pus when you were incising and draining. And as the culture and sensitivity test can take about 3 days, it must be requested as soon as a sample of pus can be obtained and before antibiotics are administered. To be useful, the sample of culture must be taken in such a way so that it favors the growth of anaerobes and fastidious organisms. Ideally, it should be taken directly from the abscess to a needle or through a sterile skin incision and transported anaerobically to the lab. Then the samples of the swabs will be contaminated by oral flora. They will be unlikely to be useful and can give you a misleading result. Now, when you interpret the results of these tests performed on a simple swab of pus, it must be remembered that these organisms are not going to be the complete representative of the infection flora, and routine culture methods in hospital will detect only a few oral flora. Unless a change to a different antibiotic is clearly justified, it is always better to consider changing the dose or route of administration. So now, how can you expect the swelling to resolve? How quickly you can expect it to resolve? So usually, patients start feeling better within a few hours, and a noticeable reduction in swelling, trismus, pain, and fever should be observed within 24 hours. By this time, drains do not usually show pus and are removed and dressings are placed over the site. If there has been no resolution, the diagnosis, antibiotic treatment, and even the effectiveness of drainage must be reviewed. Almost complete resolution should follow in 3 to 6 days, as in your present case, right? So now I assume not just your endodontic basic diagnosis, which we learned in the last chapter of 47, which was a molar endodontic treatment, how we learned about basic endodontic diagnosis and pulpitis, characteristically focusing on the pulpitis, and to the extent where an infected pulpitis tooth can become a facial swelling, can have serious fatal consequences, may require hospital admissions, IV antibiotics. So you have learned endo in all the ranges today. Is that correct? Am I making sense to you all? Do you realize the gravity of how much you have revised and how much you have learned altogether from endo and TG? Surgical aspect, pharma aspect, antibiotic aspect, endodontic aspect. That is the true sense of interdisciplinary knowledge required for ABC. You get yourself confident in these concepts, get yourself regularly attuned to the live classes, tuned to the audio recordings. You keep yourself diligently focused on learning, and there is no other way other than getting awesome every time you're reading. Yeah, go ahead. If you have questions, you can send me. Otherwise, that would be the end of today's class. Thank you so much.